Hi everyone, it's Philip here from Vet Education. I'd like to take a few minutes today just to talk about anesthesia, more particularly how we can make our anesthetics safer for our patients. Do you know that in veterinary anesthesia, the reported mortality rates in the literature are up to 10 times higher than they are for anesthesia in people? That's kind of staggering. So what I thought we'd talk about today is how we can make our anesthetics a little bit safer. Now, you may be doing all of the next 5 things that I'm going to be talking about, but I think it's valuable to review these things periodically so that we bring them to the forefront of our thought processes for the benefit of our patients. So what are these 5 things that we're going to do to reduce anesthetic risk in our patients? Number 1, our pre-anesthetic patient evaluation. Now, we evaluate patients in our practices every day. But when it comes to anesthesia, there are a few things that we want to take note of. The first is we'll do a thorough physical examination from head to toe and everything in between on every patient that is having an anesthetic. But it's not just any evaluation. We're going to be really fussy because we're going to pick on everything that is abnormal with our patient, from conformation, breathing, cardiac sounds, body weight, clinical signs this patient may have on presentation. We're going to write all of these things down because any abnormality in a patient that is about to have an anesthetic could potentially result in an increased risk of anesthetic misadventure. So we're going to write every abnormality down. And then what we're going to do is work on a plan to normalize, rectify, or as best as possible, get this patient back to as normal a state as we possibly can prior to the time at which that patient has an anesthetic. Now, for some patients, that's going to be difficult. We may be anesthetizing, for example, a brachycephalic dog to perform airway surgery to try to render that patient more normal. And so we can't necessarily do too much in many cases about the severe anatomical abnormalities in these patients prior to anesthesia. But there will be other patients who perhaps are suffering from dehydration, maybe cardiac arrhythmias, respiratory difficulty, unusual respiratory noises. They may have clinical signs that are of concern, things like vomiting and diarrhea, maybe increased thirst. They may have weight loss, and a whole range of other symptoms that we need to evaluate the cause of and try to begin therapy for, preferably prior to our anesthetic. Number 2, be prepared. The more prepared we are for our patient's anesthetic, the better that patient's chances are of surviving their anesthetic. Being prepared has several aspects to it. One of the key things is to perform anesthetic machine and anesthetic circuit checks for every patient prior to anesthesia. A second thing is to use checklists for equipment, oxygen supply, induction drugs, emergency drugs, and the procedures that we'll be carrying out under anesthesia. The third thing about being prepared is knowing your drugs. Know the anesthetic drugs, the indications, why an anesthetic combination is being used for a patient, the potential side effects of any anesthetic medication we're going to use in our patients, and how we may be able to manage those side effects, things like hypotension, for example, or tachycardia or bradycardia, temperature loss, and those sorts of things. So know the pharmacology of the medications you're using and know how to manage any undesirable side effects of those medications. The next thing about being prepared is have a plan. I really like sitting down with veterinary nurses and technicians that I'm working with and veterinary colleagues that I'm working with in a complex anesthetic and talking about what we expect to happen when we anesthetize this patient, what our plan of action is if things go wrong under anesthesia, when we may choose, for example, to use a bolus of intravenous fluids versus using vasopressors or positive inotropes to help manage circulatory disturbances, when to reach for emergency drugs and medications, and a whole range of other things. These pre-anesthetic briefing sessions are really valuable. It means everybody's going into the operating theatre and the anesthetic with a lot more knowledge and a lot more focus about what they need to do when the patient's anaesthetized. And finally, which is kind of related to the last step, have all of your emergency drugs on hand. Know the doses that you will give to this particular patient. Calculate the doses if you want to for that particular patient's size, so that in the event of an extreme emergency where you are required to use emergency medications, you have a pre-calculated dose already written down that you can draw up with very little delay and administer to your patient in a timely manner. Number 3, in our journey through making our anesthetic safer, and that is to monitor. Monitor everything you can in every patient that you have anesthetized. Review the stages and planes of anesthesia. Know when your patient's getting too deep and have a plan of action for lightening that patient up or raising their level of anesthesia to a safer level if they get too deep. Related to that last statement is beware the big pupil. A big dilated pupil associated with a loss of corneal reflexes or corneal responses is usually associated with a patient who is too deep under anesthesia. And this patient needs to have immediate measures to lighten their plane of anesthesia. The patient with big dilated pupils that has palpebral reflexes is going to jump off the table unless we get that patient a little bit deeper. So beware the big pupil. The patient is leaving the table, either because they're too deep or because they're too light. The third thing about monitoring is use your eyes and your ears and your fingers. Our senses are key to monitoring our patient's anesthetic. Use an esophageal stethoscope. They're wonderful tools for being able to determine whether or not our patient has a steady sinus rhythm at an appropriate rate, or whether the heart rate is slowing, or whether it is getting fast, or whether or not the heart rhythm is abnormal. Use your eyes to look at pupil position and size and reflexes. Use your hands to determine jaw tone and other reflexes. Anesthetic monitors are no substitute for your senses. So make sure you are evaluating your patient thoroughly using your own hands, eyes, ears, and other senses. And don't just rely on monitors to tell you what's wrong with your patient. And finally, while we are talking about monitoring, we will talk about monitors, because if you've got a monitor for use in patients under anesthesia, then connect as many things as you can to your patient, because the more intensively we monitor our patient, the earlier we'll be able to detect abnormalities that may be arising in our patient. Things like alterations in heart rate, which we alluded to just before, but changes in blood pressure, changes in end-tidal carbon dioxide concentration, changes in cardiac rhythm, changes in body temperature can all herald impending anesthetic disaster for our patient. So use as many monitors as you can in your practice, but your monitoring is more than just attaching the monitors. Use the information those monitors give you to plot trends in your patient's key vital statistics. And if they are trending away from normal, act early to remedy the problems. Don't ignore abnormal findings until they become really significant for your patient. Number 4, fluid therapy. Traditionally, we've given quite high rates of intravenous fluids, 8 to 10 mils per kilo per hour to patients having anesthesia. under the misguided impression that somehow these high rates of intravenous fluids might mitigate some of the hypotension that we observe in patients that are anesthetized, secondary to things like the anesthetic medications they may be having, hypothermia, and so on. However, evidence has shown that high rates of intravenous fluids don't necessarily mitigate the decrease in blood pressure secondary to anesthetic medications or hypothermia. Secondarily, high rates of intravenous fluids are associated with increased amounts of interstitial fluid, but increased quantities of interstitial fluid in the gastrointestinal tract and the lungs can cause quite profound tissue dysfunction. This has led to a change in recommendations for surgical rates of intravenous fluids for patients that are under anesthesia. We're now using rates in cats that are more akin to maybe 3 to 5 mils per kilo per hour, as opposed to 7 mils per kilo per hour. And in dogs, we're more likely to use fluid rates around 4 to 5 mils per kilo per hour, as opposed to rates of up to 10 mils per kilo per hour. So decreasing the intravenous fluid rate for patients under anesthesia is what is currently recommended. Now, I can hear some of you saying, Phil, what if my patient becomes hypotensive? That's a great question. The treatment for that hypotension really depends on the cause of the hypotension. If the cause of the hypotension is hypovolemia, in which a patient perhaps may have lost a large amount of fluid, either through hemorrhage at the time of surgery, perhaps massive fluid loss through the gastrointestinal tract and so on, then by all means, a fluid bolus may be appropriate. However, if the hypotension in your patient is due to a significant decrease in the heart rate of the patient from its pre-anesthetic level, then fluid therapy has not been shown to be of any value at all in improving blood pressure in those patients. The correct thing to do is to remedy the decrease in heart rate. So yes, we do use boluses of intravenous fluids in certain situations in which a patient is hypovolemic and maybe in patients that are dehydrated that we're needing to rehydrate under anesthesia. But as for the blanket maintenance of a patient on up to 7 to 10 mils per kilo per hour on intravenous fluids, just because it's anesthetized, that practice has been replaced by much more modest fluid administration rates. And finally, in the 5 steps to helping improve patients' anesthetic recovery is to recover our patient. Once our anesthetic period has finished and we begin waking our patient up, they're transferred to the recovery ward, we need to make sure that we are monitoring these patients with the same intensity as we were when they were anesthetized. There's a good reason why we need to do this. There was a large study, a SEPSAF study carried out in the early 2000s that looked at tens of thousands of canine and feline patients that were receiving anesthesia in small animal practices in the United Kingdom. And out of that study, it was found that the period of time with the highest anesthetic mortality was in the post-anesthesia period, the period from when we extubated the patient to the time when the patient was supposed to be waking up. So this is a period we know that our patients are at high risk of dying in. So you and I need to be really vigilant about monitoring and keeping a really close watch on our patient during anesthetic recovery up until the point that that animal is fully recovered from its anesthetic. Think about it this way. A patient that has just been extubated has reduced gag and swallow responses. It is unable to stand. It has abnormal consciousness. It is more likely to perhaps regurgitate and vomit. Okay, and coupled with reduced laryngeal protective reflexes, this animal is perhaps at a higher risk of developing aspiration pneumonia. Imagine that a patient presented to your clinic through the reception in that clinical state. How closely do you think you'd monitor a patient that was in the waiting room and subsequently transferred into the intensive care or treatment area if it was non-ambulatory? It had altered CNS responsiveness. It had reduced gag and swallow responsiveness. It had potential for aspiration pneumonia to develop. It may be hypothermic. It may have moderate to low blood pressure. We would monitor that patient incredibly intensively. And this is the mindset that I think we need to apply to patients that are recovering from anesthesia until they are, as the phrase suggests, fully recovered from their anesthesia. So those are my 5 tips for improving anesthetic safety in dogs and cats. There are many other things that we as veterinarians, veterinary nurses and technicians can do, obviously, but these are 5 readily achievable things. I hope that you found this a useful recap on how we can help our canine and feline patients out under anesthesia. If you'd like to know a little bit more about veterinary anesthesia, Vet Education is holding a free webinar coming up on February the 15th on the top 5 anesthetic differences between dogs and cats. It's going to be a lot of fun. We'll talk about the peculiarities of cats in particular, as opposed to their canine compatriots, and how we can help our feline patients do even better with this knowledge. We've also got a course called Essentials of Veterinary Anesthesia. It's a 4-week-long race-approved online course for veterinary nurses and technicians. It starts on the 20th of February. As I said, it runs for 4 weeks. There will be, in the course, there'll be live tutorials, message boards, loads of interactions, practice resources and protocols for you to adapt to your practice, and a whole lot more. I hope you can join us for either the free lecture on the top 5 anesthetic differences between cats and dogs on February 15th, or for the Essentials of Veterinary Anesthesia 4-week online course starting February the 20th. Hey, thanks for listening, everyone. I hope you have a great day.